Hello, everyone. Welcome back to part 2 of 3 of our week 4 lecture for outpatient billing and reimbursement. Part 2 focuses on the CPT code system. Please be advised that these 3 chapters for this week just really provide a very basic presentation of these code sets, which is why you have a full blown class on diagnosis coding, CPT coding. So, here are the objectives for this particular chapter. And CPT is a system that is owned, published, copywritten by the American Medical Association. It includes codes for procedures and services provided to patients to show what happened today. Now, CPT is considered to be level 1 of the Healthcare Common Procedural Coding System, also known as HCPCS, and HCPCS actually contains 2 levels. Level 2, which is actually known as national codes, but they are the HCPCS code manual. I'll talk about that in part 3 for chapter 8. All right. So I mentioned that the CPT code set is going to show what happened today, and it is used for professional billing when you are coding for the provider. And the provider is, physicians or nurse practitioners or physician assistants. CPT is also used for outpatient hospital services. But let me just be clear in something. CPT is used by the provider no matter where the patient is seen. And as you're learning in CPT, which you're taking simultaneously with this course, CPT has codes like evaluation and management, and they show, that a service was rendered in a hospital or a clinic or emergency room. And so CPT is used for outpatient hospital procedures. But if you're coding for the hospital and it's an inpatient service, as we discussed in part 1, you're going to use ICD 10 PCS. You already know about the concept of medical necessity, but I'm going to say it again. CPT shows what happened today. ICD 10 CM shows why. And when appropriate, we use a HCPCS code to show what we actually used. So, because this is a insurance course, one concept that is not new to you, that is discussed in this chapter, is the relative value unit. Now, you may remember in a previous course talking about different reimbursement methodologies that CMS has established. Well, RVUs, relative value units, represent the cost of the provider doing their work. But it's not just the cost. Relative value units include 3 components: the work that's involved, the expense associated with providing the service, and then malpractice insurance. So, if you think about the CPT codes themselves, some services are um, a higher practice expense, have a higher work component, and also by nature of the procedure has more malpractice expenses associated with it. And so, an office visit is going to be reimbursed less than, like a surgical procedure. So, just something to keep in mind. The other thing that I should note is that the reimbursement for a service can vary based upon a geographical location. So, for example, here in Chicago, a service would be reimbursed more than it would be for like downstate Illinois because the 3 components, work, practice expense, malpractice expense, are lower in that area. All right, so let's look at the categories of the CPT code set. And you're probably thinking, hey, this is a good review because we talked about this in week one of our Introduction to CPT and HCPCS coding course. So the CPT manual itself has three categories. The main category is category one, which includes our codes for procedures and services. That category is divided into six sections. Those six sections are further subdivided into unique categories. Then we have category two codes, which are tracking codes. The use of these codes is optional. And then we have category three, which is for the latest and greatest way to do something. So all of these codes are 5 characters. However, category two codes typically end in a letter, or they end in a letter. And I think they end in a letter F because that's escaping me right now. And then our category three codes also end in a letter, but they end in a T for temporary. And that actually makes complete sense, right? So here are the six sections of the CPT code set. The evaluation and management section is located at the beginning because these codes are reported by all specialties. And the medicine section, just want to remind you, is not medication. It is basically everything they couldn't fit in the first 5 sections. They're in the medicine section. So, as I mentioned, the CPT codes are 5 characters in length. And when you look at them in the main portion of the code manual, you're going to see a format that is known as a standalone code and an indented code. And here's the reason that we have this set up. So, number one, it is not feasible to repeat the description of um, procedures over and over and over again. And what do I mean by that? So the procedure could be, and the example that they give in the textbook is 27780, could be XYZ procedure. And the standalone code says without manipulation, and the indented code says with manipulation. Same procedure, one has manipulation, the other doesn't. So the indented code will just say something like with manipulation. However, the indented code relies on the description of the standalone code to give the full description of that code. I encourage you to take a look at two 277 27780 and 27781, I think, are good examples. All right. The CPT manual has multiple appendices, which are located immediately after the category three codes. These appendices each have a unique purpose, definitely something that you want to review to become aware of what they are and when you would need to use them. Just like ICD 10 CM, CPT has some symbols and conventions, and I like to say CPT probably has more symbols. These symbols are located throughout the CPT manual and provide guidance for proper code assignment. It should be noted these codes or these symbols do not go on or are not reported with the code. They are just providing you with some information about the code. And as you can see, a new code, revised code, they each have a unique purpose. And so you'll want to take some time and review those. Again, this chapter is in our reimbursement book. So I'm not going into great detail. For great detail, you'll want to go to our lecture for the CPT HCPCS coding course. So I mentioned that category one is organized into six sections. Those six sections are further subdivided into subsections. And as I mentioned before, each area begins with what are known as guidelines, and these guidelines are located at the beginning of each section. You should carefully review these guidelines before assigning a code. Now, in addition to the guidelines, which are located at the beginning of each section, in the different subsections, you're going to find more notes, such as parenthetical notes, subsection notes, and now is the time to review this information prior to sitting for a national exam, because on the day of the exam, you don't want to be seeing something for the first time. The CPT code set does have a set of unlisted procedure and service codes, and these are assigned when your provider performs a procedure or service, but there is no unlisted code. But here's the catch: whenever you report an unlisted code, we must include what CPT calls a special report, which is basically the report that documents the service. And this report needs to show six things: the nature, extent, need, time, effort, and equipment to perform that particular service. And the reason that this is needed is because there is no reimbursement for an unlisted code. And so they're going to look at the report to make a determination as to how they're going to pay for that service today, or what they're going to pay. So I talked about the instructional notes or notes. And so here is a list of the different notes that are available. I must just overemphasize that the day of the test is not the day to see something in your manual for the first time. You pay a lot of money to sit for national exams, and you don't want to, you know, waste your money by not reading the information up front. All right, so CPT descriptive qualifiers. So these are terms that clarify the assignment of a CPT code, and they can occur in the middle of a main clause of a statement or after the semicolon, and may or may not be in parentheses. So, having said that, it is very important that you carefully review the CPT codes that you're looking at so that you can understand the intent behind each code. So, for example, and this is actually so I do some work with physician assistants and looking at their coding when they're doing their clinical rotation. And I often see this example that's in the book, and the CPT code 17000 and 17003, which is the destruction of a lesion. So 17000 is actually the first lesion, and then that's the descriptive qualifier, and then 17003 is actually the code that says second to 14 lesions each, right? Second through 14 lesions each. And I commonly see providers reporting the code that says second through 14 lesions, but they did not report the code for the first lesion. All right, foreign body and implant definition. So in surgery, radiology, and medicine, there are guidelines that clarify regarding foreign body and implant. And so you see, They talk about an object that is intentionally placed is considered an implant. Something that is unintentionally placed is a foreign body. They give you some more discussion on that, and you can continue reading that. So, the index, which is located in the back of the CPT manual, is where the coding process begins. And unlike the diagnosis coding system, so in diagnoses, the index is in the front. CPT, the index is in the back. And so the CPT manual, just like CM, is organized by main terms. It's a bold face print. But with CPT, we have four categories of main terms. And basically, what that means is don't say you can't find a code until you try one of these four: procedure or service, organ or anatomic site, condition, synonym, eponym, or abbreviation. Once you get to your main term, then you're going to look at your subterms, and you will notice the main term versus the subterm because the subterm is going to be indented. And sometimes they are further modified, indented by additional, I call them subterm to the subterm, that you will need to pay close attention to. All right. When you are in the index, one of the things that you are going to notice is that they will provide you, after you go to the main term or subterm, they will provide you with a single code, a range of codes, and the range is going to be separated by a hyphen, or a series of codes, which are separated by a comma, or it could be a combination of all of that. And basically, anything that they give you in the index, you got to verify in the main portion, right? It's the same thing with all coding systems. You have to verify. So, in the index, you may also see cross references such as C and C also. And so, you want to make sure that you are doing what you are told to do, right? So, if it tells you to see something, you should see what is available. So, the steps: you read your documentation, you are going to ensure that you have read the guidelines at the beginning of each section. You already know the importance of reading the introduction to the CPT manual. So you got your medical record. From the medical record, you are going to identify what you're going to be coding for today. You're going to use those four primary classes of main terms. Under the main terms, you're going to go to the subterms, and you're going to get your codes that you want to consider in the main portion. And then, you're going to continue coding until you've coded everything that you need to code. And when appropriate, you are going to assign a CPT modifier to the end of that CPT code. And as you all already know, you had a whole lecture on CPT modifiers. So go back to the lecture on modifiers to refresh on that topic if you have forgotten it already. One of the things that I absolutely love about the insurance book is that it really goes into some examples of visual of what it's going to look like on the claim form. So here's an example of a scenario where a patient went through a procedure called an arthrodesis, and it was bilateral. And so if you notice on this particular snapshot of the claim form, it is showing you where that modifier is placed. Now, real world, we plug this information into a computer, and then the computer system knows where to place it electronically on the claim form. Now, one thing that the chapter does call out is the fact that there are basically two types of modifiers. Your other book called them, I think, something a little different, but the concept is the same. So you have a functional modifier, also known as a pricing modifier or a payment modifier. That modifier is always going to be sequenced first in the little boxes here. You see that? And it basically clarifies um, what is impacted from a pricing perspective. And then the second type of modifier, if it applies, would be an informational modifier. So in the textbook, they give you an example of a procedure that has modifier 80 in the first position as the functional modifier or the pricing modifier, and then a modifier RT for the right side. So basically showing that the assistant surgeon worked on that procedure and the procedure was done on the right side. All right, so on to the different sections. So, evaluation and management codes are listed first. They are used by all specialties. And before you get surgery and x ray and labs and all the things, you have to have the evaluation and management service done first. And there are all sorts of evaluation and management services that are available. And these services are basically when that physician is coming in contact with that patient, they're they're having a conversation about the patient's problem, they are examining the patient, and then they're coming up with an assessment and plan of what they are going to do next. Again, just please keep in mind that in our CPT class, you have your full blown lecture of evaluation and management. But one key characteristic of some, not all, of the evaluation and management codes is the complexity of medical decision making. And from a reimbursement perspective, the more complex the medical decision making or the total time spent on the date of the encounter, the reimbursement is going to be higher. And I like to always say it has to be um, supported by medical record documentation. That is the name of the game. You can't just list a code and say, um, this is what happened without having that reflected in the documentation. All right, next up, our second section is the anesthesia section. And as you know, the anesthesia section is used for our CRNA, certified registered nurse anesthetist, or our anesthesiologist, who is a physician. And this is basically the work that is involved for the patient to be comfortable during a surgical procedure. And you may also remember that your surgical procedure codes include more of a local anesthetic, whereas the anesthesiologist evaluates the patient, administers anesthesia to keep them comfortable during the surgical procedure, and they remain with the patient until that surgical procedure is over. When we talked about the anesthesia section, we also talked about the fact that there are physical status modifiers. We talked about, and that was actually just last week, an anesthesia formula. We also talked about what are known as qualifying circumstances, add on codes, which happen to be, from a placement perspective, they're in the medicine section of the CPT manual, but we use them in anesthesia. And if you look at your anesthesia guidelines, they are actually located there as well. And by now, when you're coding for the anesthesia provider, in the index, your main term is going to be anesthesia, because if you don't select anesthesia as your main term, you could get to a surgery code. In the textbook, they also remind you about those HCPCS anesthesia modifiers. And so I think, again, this chapter presents a great mini review of what we cover in our CPT course. On to the largest section of category one of the CPT manual, and this is the surgery section. Each subsection is organized by a specific organ or anatomic site, right? So I think there are like 11 subsections. Don't quote me. I can name them, then I could probably count them. But nonetheless, each of the sections have categories that further subdivide the different procedures. So you're going to see, again, first the anatomic site or the organ, and underneath those areas, you're going to see things like incision, excision, repair, revision, destruction, suture, on and on and on and on. And to properly code a surgical report, there are some questions that you should keep in mind as you are reading the operative report. So, what body system was involved, what anatomic site, what type of procedure was performed, and it is also important to note what approach was done, right? Was it an open procedure, or was it a procedure that um, is using some type of endoscope? And endo means to look within. Of note, section two is section, or I should say, part two of this lecture is the longest of the three. All right, so I'm almost done though. All right, so in the guidelines for the surgical section, they talk about the surgical package. And the surgical package in my mind, how I remember it, is that it includes all these things for that one CPT code. And so you see the list of services in the CPT manual. Now, it should be noted that there is a surgical package definition in our CPT manual, but then CMS, aka Medicare, established a national definition for what is known as a global surgical package. And that differs from the definition of the CPT surgical package, and the Medicare uh, goes a step further in categorizing surgeries as like major or minor. And it established what is known as a global period. And so this is the number of days associated with that package. And so basically, just regular follow up for that service is going to be based on, from a Medicare perspective, if it's a minor procedure or a major procedure, and that basically tells you how long the post op period is. In the textbook, they go way more into detail about that. So you'll want to make sure that you read that. All right, the concept of a separate procedure. So, in the main portion of the CPT manual, you will see that some codes have a note in parentheses that says separate procedure. And in the introduction to the surgery section, they pretty much, and I'll just use my own words, give you three scenarios related to surgical procedure. So let me just explain them. If this procedure that you're looking at, so let's just say a splenectomy, is the only thing that is done today, you don't need to worry about anything else. It's all good. However, if the procedure that is represented with a description of separate procedure is performed on the same day as a more comprehensive and related procedure, the separate procedure basically gets swallowed up into that more major procedure. Well, let's say that the procedure that has the words separate procedure behind it is unrelated, distinct from that other procedure. You can code both of them, but you would need to use a modifier to show that they are separate and distinct. In the book, they have a little bit more detail where they get into modifier 51 or 59. And this is basically in the situation when you have multiple procedures. And so they talk about the claim form again, just to give you that visual of, well, what happens if you have more than one surgery done today. The major surgery is going to be listed first on the claim form, and then that lesser minor procedure is going to be listed second. And when you're talking about 51 versus 59, there is a difference in how those services are paid. And I want you to refer to the textbook for additional information. All right, radiology section. This section includes four subsections for diagnostic imaging, ultrasound, radiation oncology, and nuclear medicine. And the subsections are divided based upon anatomic site. So if you go to diagnostic radiology, you're going to see the differences. You're going to see the anatomical site, and then you're going to see the procedures themselves. In the diagnostic radiology section, for example, you're going to see what is known as the number of views. This is meaning that the study itself is taken from a different angle. So if you've ever had a chest x-ray and they have you stand facing forward, and then they tell you to turn to the back, and then they tell you to turn to the side, that's an example of different views. Okay. So, in the radiology section, you will see the word complete. And do not confuse the use of the term complete in the code description with the use in a parenthetical note. So when the word complete is in the code description, one code is reported to completely describe the procedure performed. But when the word complete is found in a parenthetical note below a code, it may be necessary to report more than one code to completely describe the procedure. And so, some examples of that are situations where the patient has an injection, and then let's say it's an injection into a vessel. But in order to see, so wait, first let me just back up. So they inject, like, let's say, some dye into a vessel, but in order to see that vessel, they need some type of radiological component, and they put the dye in so that they can see it under radiologic guidance. And so you may need a code from the surgery section for the injection, and a code from the radiology section to show the looking at it. Okay. When we talk about radiological services, and let me just go back before I forget to say this. When we're talking about the radiological service, there's also a concept called professional versus technical component. And basically, it's around the fact of where the service is rendered, who owns the equipment, and we'll get into that a little bit more in our CPT class. But the book for this class actually does have a description of it, and of course, in order to complete your quiz for the week, you want to make sure that you read that. All right, so we're almost done. Pathology and laboratory, and the pathology and laboratory section is for the testing of a specimen versus the collection of the specimen. And just think about all the bodily fluids that we have in our body. That's what you will see in that area, all the different codes to test the different specimens. And then last and certainly not least, we have the medicine section, not to be confused with medication. And this particular section classifies non invasive or minimally invasive diagnostic and therapeutic procedures and services. But literally, what you could not cover in the other sections, you will see over here. And in the book, they give you this long laundry list of all the things that can be over there. But it could be vaccines, it can be EKGs, it could be injections, it could be infusions. I mean, it's got a lot going on over there. And then we get to the end of the CPT book. We know we have our category 2 and 3 codes, which both end in a letter. And category 2 codes are for performance measurement. And category 3 is for that emerging technology. All right. So this one was a little longer. We had a little bitty tiny CPT review. And next week, we will get back into some, true reimbursement chapters. We're going to get into reimbursement methodologies. But before we do that, let me do part 3 of our week 4 lecture, which is going to focus on the HCPCS coding system.